Hey guys, welcome back to the channel. If you're new here, my name is Lukas. I'm a first year ophthalmology resident at the University Eye Clinic in Germany. On this channel I produce videos about healthcare, productivity and lifestyle. The goal of the channel is to help you guys have a more productive, healthy and at the end happier life. If you like the content that I'm producing, I would be very happy if you subscribe to the channel. In case you have any question about what I'm talking, please send me a message or a comment and I will come back to you guys. As you can see, I've been very successful in the last couple of months in producing videos. So this is one of my first videos after a very long time, and today's topic is about emergencies in ophthalmology. The first bigger topic I want to talk about is ocular trauma. First of all, whenever you have a patient with an ocular trauma, do not forget that the patient could also have other life-threatening injuries as well. So priority must always be given to treat these kind of conditions. The eye should be taped with a protective eye shield until the patient is stabilized, and then it's the turn of the ophthalmologist to take care of the ocular trauma. The first trauma I want to talk about is a corneal abrasion. This is a defect in the epithelium layer of the cornea caused by trauma like a fingernail scratch. Patients usually have symptoms like pain, tearing, foreign body sensation, and the diagnosis is facilitated by a fluorescein dye which stains the part devoid of epithelium. The important thing is to distinguish a corneal abrasion from a corneal ulcer. Corneal ulcer is an infection of the cornea, and it also presents with a corneal defect. However, it usually presents with a white opacity. So treatment, first of all, you give the patient a topical anesthetic which helps to release the pain, and then if it's just a small abrasion, you usually prescribe a topical antibiotic used 3 to 5 times per day until the abrasion is healed. If there is a bigger abrasion, you can use a soft contact lens and a topic antibiotic. However, you should never use a contact lens if there is a high risk for an infection. For example, if the corneal abrasion is due to use of soft contact lenses. So the next trauma I want to talk about is a corneal foreign body. This means that an object is adherent or embedded in the cornea. Typical objects are metals, wood, dirt, plastic, glass. And high velocity foreign bodies also have the potential to penetrate the globe. So whenever there's a foreign body, it's very important to examine the cornea very carefully. Treatment, if the foreign body is not deeper than the superficial stroma, it's possible to remove the foreign body in the emergency department with a small needle. In case the foreign body is deeper in the cornea, it's better and preferred to treat the patient in a sterile setting in an operation room. The next trauma I want to talk about is a closed globe injury. This is a very huge topic, includes a lot of injuries. And it basically, first of all, means that there's a blow to the eye by a blunt object. And whenever you have this kind of injury, what's important to do, like a full examination of the eye. So you first start with the history, what happened, then you check the visual acuity, you check the motility of the eye, the visual field, pupillary examination, you do an external examination, anterior segment examination, fundoscopy, and also tonometry. That's very important. What are possible injuries? due to that trauma. So first of all, we could have a subconjunctival hemorrhage. So that is actually a self-limiting condition, so it usually does not require further treatments. Other injuries, there could be an hyphema, so this means that there's an accumulation of blood in the anterior chamber of the eye. This is what you usually can see on the bottom of the eye in the anterior chamber, and you should usually check how high is the level of the blood. Problem that can be caused by this condition is that the drainage of the aqueous humor is decreased, stopped, so that could lead to an increase of the eye pressure. So in this case you would have to prescribe an anti-glaucomatous medication. Furthermore, the patient should keep the head up so the blood can fall down and the resorption of the blood could be increased. Also often topical cycloplegics and steroids are prescribed. So in some rare cases it could be also indicated to do like a surgical treatment, but this is a bit controversial. Another condition could be iris sphincter rupture that would lead to a mydriasis of the pupil. Could also have iridodialysis, so this means that the iris is detached from its basis. In these two conditions there could be an indication for suturing of the iris. Other traumas that could occur are cataract. There could be also a dislocation of the lens. In these two cases, cataract surgery would be indicated, of course. Besides that, there could also be a traumatic iritis, so an inflammation caused to a trauma. In this case, there would be a lot of inflammatory cells and proteins in the anterior chamber that could also lead to a decreased drainage of the aqueous humor, so again increased eye pressure. So in this case again anti-glaucomatous medication would be prescribed. Furthermore, this could lead to synesthesia. So in this case you would prescribe topical cycloplegics again, and also topical steroids, anti-inflammatory drug. Other conditions could be orbital fracture, of course. Symptoms of that would be edema of the eyelids, endophthalmos, problem with the up or down of the eye. Surgical repair is indicated if there is like diplopia or an endophthalmos or an entrapment of an extraocular muscle. Other traumas that could occur, for example, a retrobulbar hemorrhage. In this condition, due to trauma, there's an accumulation of blood, retrobulbar, that is causing pressure on the optic nerve. It's also a very, very dangerous condition which could lead to damage of the optic nerve. Symptoms of this could be decreased vision, decreased motility, relative afferent pupillar defect, and proptosis of the globe. Diagnostic could be computer tomography to see this condition, and the treatment would be lateral cantotomy. Other condition could be vitreous hemorrhage. This is a condition in which the blood accumulated in the globe. Treatment option: either you could wait until the blood resorbs by itself, or otherwise there could be also an indication for a pars plana vitrectomy. Whenever there's a vitreous hemorrhage, you always also have to rule out retinal tear and a retinal detachment. If the vision is really decreased, you're not able to do fundoscopy, then you should do an ultrasound. Also, other condition could be, of course, retinal tear, retinal detachment. Symptoms of that could be floaters, could be light flashing, could be curtain or shadow appearing in the eye. And if there is only a tear of the retina without a detachment, could be enough to do laser demarcation of the area around the tear. The tear could not lead to a retinal detachment anymore. This could also be done by cryotherapy. Sometimes these therapies are also combined. In the case that there is a retinal detachment, then the treatment option would be one or a combination of a scleral buckling, pars plana vitrectomy, pneumatic retinopexy, cryotherapy or laser treatment. Another important ocular trauma is the open globe injury. That can be caused either by a blunt trauma or by an injury with a sharp object. Symptoms of this are low intraocular pressure. There could also be a change in the depth of the anterior chamber, so it could be very shallow or very deep. Both is possible. There could be a change in the shape of the pupil. There could be a prolapse of ocular tissue or marked bloody chemosis of the conjunctiva. And there could also be a total hyphema with a normal or low intraocular pressure. Whenever you figure out that there's an open globe injury, avoid to put any pressure on the globe. Cover it with a Fox shield. The patient should also be given tetanus prophylaxis. They should get antiemetics, sedatives, analgesics, prophylactic parenteral antibiotics. And whenever there is an intraocular foreign body suspected, they also should get further diagnostics like computer tonometry, and in the operation room there should be done the definite repair. The next bigger topic of ocular emergencies I want to talk about is ocular infections. The first one I want to mention is the acute conjunctivitis. This usually presents with symptoms of red eye, ocular irritation and discharge. The most common cause of this is virus. Patients usually present with watery or mucus discharge and preauricular lymphadenopathy. Compared to bacterial conjunctivitis, patients usually have more mucopurulent discharge. Patients with viral conjunctivitis usually are considered to be contagious for around 10 days. Treatment, all you need is cold compresses and artificial tears. For bacterial conjunctivitis, treatment option would be topical antibiotics. The next infection I want to talk about is the Microbial Keratitis. This is an infection of the cornea caused by bacteria, virus, fungi or parasites. The most common cause is bacteria, and symptoms of this are pain, decreased vision, conjunctival injection, white infiltrate in the cornea. It's usually due to wearing contact lenses. Fungal keratitis is much less common, and it's caused by trauma to the cornea from plants or vegetable matters. This kind of infection is usually more indolent, and the corneal ulcer has feathery margins and satellite lesions. Keratitis due to parasites like Kent amoeba is usually in early stages non-specific. In later stages there could be a deep stromal infiltrate. For example, this could be ring-shaped. The treatment depends on the cause. So for bacterial ones, you would use, of course, antibiotics. Fungal keratitis, the treatment would be antifungal medications. And for infection with acanthamoeba, you would use propamidinisetionat and polyhexamethylene biguanide. Yeah, I'm sorry, I really have to read that from the script. And I'm sorry for my German pronunciation. Viral keratitis could be caused by an infection with the herpes simplex. Symptoms are pain, decreased vision, tearing, preauricular lymphadenopathy, dendritic ulcer, decreased sensation of the cornea. Treatment for this would be topical and oral antivirals. The next infection I want to talk about is the endophthalmitis. This is a very, very dangerous infection, purulent infection of the intraocular fluids, so the vitreous and the aqueous, can be caused exogenous due to a cataract surgery or corneal ulceration. It can also be caused endogenous due to autoimmune deficiency, cardiac valvular disease, intravenous drug use, or indwelling catheters. Symptoms of this infection are reduced vision, pain, red eye, anterior chamber inflammation, vitritis. Patients with this kind of infection have a really high risk for blindness. So immediate treatment is necessary, which is usually injection of broad spectrum antibiotics intravitreous and intravenous. So whenever you're working in medical field or you find a patient with this kind of symptoms and you're thinking this could be this kind of serious infection of the eyes, please contact an ophthalmologist, and if this saves the vision of some people due to this video, that would be really, really, really cool. The next ocular emergency I want to talk about is the acute closed angle glaucoma. This is a condition in which the iris is opposed to the trabecular meshwork, which decrease the aqueous humor drainage. Symptoms of these conditions are red eye, nausea, vomiting, headache, shallow anterior chamber, increased intraocular pressure, a mid-dilated pupil that does not react to light anymore, and also a hazy cornea due to epithelial edema. Treatment for this condition is to reduce the intraocular pressure with anti-glaucomatous local therapy, and also to use pilocarpine. This helps to make the pupil smaller, and this helps to remove the iris from the trabecular meshwork. Besides that, could also be necessary to prescribe analgesic medications. Definite therapy would be laser iridotomy or surgical iridectomy on both eyes. The next topic I want to talk about is the central retinal artery occlusion. This is caused due to an obstruction of the arterial blood flow through an embolus or a thrombus. And symptoms are unilateral, painless, severe vision loss. And the patient also has a relative afferent pupil defect and gray or white retina, except of a cherry red spot at the fovea. The prognosis is often poor, and this condition should be treated like a stroke so patients need neurological consultation. Furthermore, if the onset of the symptoms is within 4 hours, then there's an opportunity to give the patient intravenous tissue plasmogen activator. Furthermore, it's also important to rule out a giant cell arteritis with an ESR if the sedimation rate is increased and also other symptoms for giant cell arteritis are existing, then the treatment option would be high-dose prednisolone. Last emergency I want to talk about is the Arteritic anterior ischemic optic neuropathy. This usually presents with symptoms of unilateral, painless, severe vision loss, also with headache, with scalp tenderness, with jaw claudications, with visual field loss, and in the fundoscopy you would see a swollen optic nerve and inflamed hemorrhage. Besides that, patients also often have fever and weight loss, and the treatment for this would be high-dose corticosteroids, intravenous. Patients will also get a temporal artery biopsy, and if the disease is confirmed, then they would also get oral prednisolone for like 3 to 12 months. It's very important to start this treatment immediately, because otherwise patients also have a really high chance of like 95% to get same severe vision loss on the other eye within the next couple of weeks or months.